Hello, and welcome to this Facebook Live event run by Modality Partnership. I'm just going to do a bit of an introduction and sort of say hello to everyone. From my understanding, there should be patients from AWC Modality, Hull Modality, as well as also from the Birmingham site. I'm just going to sort of get us started here and sort of introduce the people that we've got with us tonight. So my name is Josh. I am one of the practice pharmacists down in AWC Modality. And I work here as a clinical pharmacist doing sort of management of medicines that people are on. So, but this evening we are joined by two lovely doctors and partners from different sites, and I'll let them introduce themselves shortly. Just a little bit of housekeeping, I guess. We will be looking through the chat box throughout the Facebook Live and the YouTube Live. However, we won't be answering questions until the end. So I will do put your questions in the chat as you go along, and we will obviously keep an eye out for them. But don't be worried if we don't answer them straight away. We will be coming back to them at the end once we have gone through the slides and obviously gone through all the information, because you never know, your answer might already be in the slides themselves. So with that being said, I am going to hand over, I think it is to Dr. Vipan, who will be looking through and helping us through the slides at first. And there's obviously, we will go from there. So.
Thank you, Josh, and good evening, YouTube, and good evening, Facebook. Those are comments that I never thought I'd be making in my medical career. I'm going to, and I'm also going to utter the dreaded words. I'm going to share my slides, which I'm hoping is happening now. Perhaps Josh or Tom, you could just confirm that for me.
I will do, and they haven't been shown yet. Oh, there they are. Perfect.
Excellent. So a really warm welcome, everybody. It's a real pleasure to have an opportunity to work with you on an area which is pretty tough at this time of year. Health can be quite problematic over the winter, and so I hope that tonight's session is going to be informative, interesting, maybe even inspiring. That would be nice, but most of all, hopefully practical. So my name is Vipan Bhardwaj. I am a GP partner in Wokingham in Berkshire, and I'm joined by my colleague, Dr. Tom Ratcliffe, who's a GP partner in Yorkshire. And as you can see from the slide, Dr. Ratcliffe is the lead for Modality Partnership's Digital Transformation Group. And this is a team that is responsible for the background work that's gone into this session tonight and also to this program more widely. And as you'll see, that's a fairly Herculean effort. My role, or one of my roles within Modality, is that I am the National Lifestyle Medicine Clinical Director. Now, lifestyle medicine is not a term that I'm particularly fond of, but I just have to get on with it because it's an accepted sort of speciality in medicine. Lifestyle medicine really focuses on doing the basics, doing the fundamentals, so that we hopefully don't have to medicate people quite so much. Exactly what those basics and fundamentals are, we'll go through in the slide deck. You'll see at the top of the slide, this says declarations of interest. What's that all about? And that's really reassurance for you that Dr. Ratcliffe and I we're basically NHS GPs, and that's pretty much all we do. We are not, as will probably become fairly abundantly clear during the course of this session, we don't really receive any kind of drug company funding for this. We are not here touting any books or sort of weird potions and pills. We're full-time NHS GPs, and that's it. So this is what we're going to cover this evening. This session will last about an hour, and this presentation will take about 20 minutes, and the remainder is all so that we can answer your questions. We're going to start with an introduction into why this topic is important. Why have we got a session? Why have we got an entire program? And why is it that diabetics and those living with high blood pressure are at extra risk of ill health over the winter. We'll indulge in a little bit of science, nothing too scary, just enough hopefully to give you some insight into the particular issue, why there is that greater risk and how our program actually works. We'll outline some of the lifestyle factors, that word again, and in a sense cover the fact that Dr. Ratcliffe and I maybe slightly unusually would much rather not stick you on extra pills, but would actually hopefully improve your well-being without that. And then we'll round off by introducing you to the Health and Wellbeing app that as modality patients you have access to, and through the app to health and wellbeing coaches. More of that towards the end of the presentation. So here we go. And this slide in effect is a bit of a summary slide of the entire presentation. So this is a paramedic standing in front of an ambulance, and I think that most of us would agree that we never really want to be taken to hospital, and we certainly would rather not be carted off to hospital in an ambulance. So in the nicest possible way, we would prefer not to meet this kind of chap. And that's what tonight's session and the program more generally is all about: keeping you well, keeping you so well that you don't need to go to A&E and definitely don't need to be hospitalized. Now, most of you present tonight will have received a personal invite because you have diabetes or high blood pressure or both. And as you can see at the bottom of the slide, high blood pressure is the medical term for that is hypertension. So during the course of these slides, I may well use those terms interchangeably. Those of you who have diabetes and hypertension are at greater risk of ending up in A&E and therefore a greater risk of needing this chap's services. Those of you who have not received an individual invite, you're very welcome, and you're actually very welcome to join the program. There's an email and a phone number that you'll just need to utilize to contact us to let us know that you'd like to join the program, and those details were on the landing page that you utilized in order to join this session. So here's some data, and this is with due apologies for those of you who are allergic to graphs, but I promise there's only one. Now, I'm going to start by indicating that this slide is the product of a 10-year analysis of 220,000 modality patients' medical records. I'll perhaps just say that again. 220,000 patients' records have been reviewed going back over 10 years. That's a lot of information. So what are we looking at? We're looking at a graph showing who is most at risk. At risk of what? As already stated, at risk of becoming ill over winter and potentially ending up in A&E, or maybe worse, being admitted to hospital. So along the bottom, we have patients with combinations of what we call long-term conditions. Long-term conditions, as the name suggests, are conditions that people live with long-term as opposed to short-term. And this particular set of data is for people living with 3 long-term conditions. We actually have similar graphs looking at 2 long-term conditions, and they're very, very similar. And on this side of the graph, we have the numbers of patients living with those conditions who are at extra risk. And what you can see is that there are some patterns here. And I've got to say that the first time I got sent this data, I practically fell off my chair, because what you can see is who is at most risk. In other words, who is most vulnerable of getting poorly and ending up in A&E. And as you can see, it's diabetes and hypertension are massively overrepresented. So you can see all across, it's either diabetes and hypertension or diabetes alone. And given that this is a 10-year analysis of 220,000 patients, this is telling us something very, very important, something profoundly important. What that is I'm just going to keep you in suspense for another couple of slides, and I'm going to come back to in a few minutes' time. Now, at the bottom here, we've referred to metabolic conditions. That's a term that some of you may be unfamiliar with, but there is a thing called the metabolic syndrome, and it's very easy to define. There are four parts of the definition. We've got this fine fella over on the left who's carrying a little bit too much weight around his tummy. That's one of the parts of metabolic syndrome. Lipid problems, in other words, blood fats, not actually cholesterol particularly, it's much less important. Hypertension, in other words, high blood pressure, and type 2 diabetes. If you have three of those four components, you have the metabolic syndrome. And what this slide shows is how some other conditions are actually also linked to these conditions. And some of these may well be slightly surprising. Dementia, some people still refer to dementia as type 3 diabetes because there appears to be a correlation between diabetes and Alzheimer's dementia. It's been known about for a very long time that one of the risk factors for developing cancer is carrying too much weight around the abdomen. So these things they seem to be related. And again, that is telling us something very important, which I'm going to come to in a bit. So, promised you a little bit of science, not too much though. The first thing to say about this slide is that there is absolutely nothing on this slide which is remotely controversial. This is school level science, and it's been known about for decades and decades. Everything that happens in our bodies is as a result of our hormones. Metabolic syndrome, that combination of diabetes, blood pressure, abnormal blood fats, and being overweight is largely the product of two hormones which are mentioned on this slide, insulin and cortisol. I'm going to start with insulin. Insulin is responsible for storing fat. What insulin does is it basically shoves glucose, which we sometimes refer to as sugar, it shoves glucose out of the bloodstream into the cells, where it then gets turned into fat. The higher the insulin levels, the more the fat storage. Now, straight away, that doesn't sound great. Does it? Anything that promotes fat storage, most of us would agree we're not all that happy about. But it's actually worse than that, because what it also does, insulin, is acts on the kidneys to retain salt. And when that happens, our blood pressure goes up. So the higher the insulin level, the more fat being stored, and the higher the salt retention, and therefore the higher the blood pressure. None of that sounds particularly appealing. So if we're thinking about this from a practical proposition, we are probably going to think about what may be causing those insulin levels to be high. Well, that'll be, as you can see over on the left-hand side, that'll be starch or carbohydrate in our diet. And you can see some of the common kind of sources of high carbohydrates: rice, pasta, bread, noodles, potatoes, fruit, and also the sort of the naughty stuff like cakes and pastries. And so the way to think of this, the way that I like to think of this, is that a starch is in effect 1,000 Lego blocks all sort of joined together. If we break those 1,000 Lego blocks down into one Lego block, and we're left with one Lego block at a time, that's a glucose or a sugar. But when they get broken down, when the starch that we eat in the diet gets broken down, it gets broken down into those 1,000 Lego blocks, those 1,000 glucoses, and that causes those insulin levels to rise. On the other side, we've got cortisol. Cortisol is less important from a diet perspective, but it's very important from, as you can see, the lifestyle perspective, particularly things like stress, poor sleep, not enough exercise, etc. And what cortisol does is it increases the glucose and sugar in our bloodstream in response to these kinds of things. So cortisol is often called a stress hormone. And so if cortisol is increasing the blood sugar, well, that's going to lead to high insulin levels. And before you know it, we've got a real kind of double whammy going on here. And in a sense, this slide is almost a summary of modern life, isn't it? We've got people probably eating way too much carbohydrate than is healthy for them, and simultaneously feeling stressed, not sleeping very well, etc. And when we consider that, it's perhaps little wonder that we have really a bit of a public health crisis on our hands. We have around about 2/3 of the English population either overweight or in the obese category. And since the 1960s, the diabetes rates have increased 12-fold and are expected to almost double just in the next 6 years. Now, some of you may have joined Modality on a previous Facebook Live, and that was called Heart Disease, Know Your Numbers. And you may well have seen these numbers in a slightly different format. If you haven't and you're curious, then that session is on our YouTube channel. Now, I won't necessarily go into all of these numbers in forensic detail because lots of numbers can sometimes be a little bit off-putting. But again, this session will be available on YouTube to be viewed afterwards, so that you can always come back to this. But for those of you who are diabetic, these numbers may hopefully mean something. HbA1cs, for those who need a little refresher, HbA1c is how we measure diabetes control. It's how we diagnose diabetes, and it's how we also measure control. Anything less than 41 off medication, we actually count that as diabetes in remission. 42 to 47 would say that's in the pre-diabetes range. Those are good numbers to have. Anything in the 40s is good. The NHS actually counts 48 to 58 as okay control. Up to sort of 58 is regarded as pretty decent control. Above that, not so good. You can see what sort of blood pressure targets we'll typically be going for. And then over on the right-hand side, the weight. And this is in this thing called a body mass index, which is a way of making a ratio of height and weight. Staying well this winter, but without more pills. And why is the without more pills important? Well, the reason is actually very simple, and that it relates to how we arrive at the numbers on that previous slide. So let's say, for argument's sake, we want to die. We say that a diabetic has an HbA1c of 45. How we get to that 45, whether it's through medication or whether it's through lifestyle factors, is incredibly important. And what is remarkable is that the effect on somebody's health is less on medication than it is through lifestyle factors. Let me say that again. If you arrive at a certain HbA1c or a blood pressure and you do it through the basics, which are sort of listed on this slide, that actually has a greater effect on health and well-being. And let's face it, keeping people out of A&E and keeping people out of hospital than doing it on medication. And that's because of a word that I haven't mentioned yet, and that word is inflammation. And that is the message that I was teasing about slightly earlier on. So dealing with diabetes and high blood pressure by dealing with the fundamentals means that inflammation is tackled at source. And that's critically important, because we tend to think now that diabetics in particular, but probably anybody with metabolic syndrome, is living with consistently high levels of inflammation. And we're okay whilst we're okay and we're not suffering with any other illnesses. But winter comes along and we start to get more in the way of coughs and colds and other types of infections. And that balance, that just about coping with that inflammation, the balance disappears. And before you know it, then the infection has got out of control because of the metabolic syndrome inflammation, and you'll end up in A&E or hospital. And that's almost certainly why we have found on those previous slides that diabetics and those living with high blood pressure are at much greater risk of ending up in hospital. So that's the background, and that's the sort of the science, if you like. what we're now going to go into over the next few slides is the practical bit. This is how we hope that we're going to get you, or you're going to remain in good health and not land up in A&E, and not just for this winter, but hopefully every winter to come. Now, there are lots of versions of this. Here we talked about 8 lifestyle factors for optimum health. There are other versions which are sort of 4 or 5 or 6. The general message is a very similar one, and we don't necessarily have the time to go through all of those in sort of forensic detail tonight, but all of the information from this session and more will be uploaded into the app, and that's where the coaches will be able to help you. So hopefully now this will not come as any great surprise, talking about carbohydrates and the effect on insulin levels and all of the bad things that happen. It won't be surprising that one of the proposals that we have is to actually reduce carbohydrates substantially more than most people are having. Many people will be quite happily eating 500 grams and more of carbohydrates per day, and our recommendation is just a simple reduction down to about 100 to 120 grams per day will be beneficial. It'll reduce the insulin levels, which reduces the fat storage, reduces the inflammation, reduces the salt retention at the kidneys, reducing blood pressure, etc., etc. In an ideal world, we'd be doing that through non-processed food, but the budget doesn't always allow that. But talking about the budget, one of the remarkable things about this kind of approach is that it's actually cheaper. When carbohydrate levels go down, those insulin levels go down and they stay much more stable. And as a result of the lower carbohydrate diet, the sort of ups and downs that often occur in glucose levels, insulin levels, energy levels, those ups and downs are much reduced. And what's remarkable is that hunger is also substantially reduced as well. And so it's perfectly fine to not be eating 3 meals a day plus snacks. It's perfectly okay, as many people who eat this way do, is to eat maybe twice a day and to skip a meal. And what does that do? It actually keeps those insulin levels even lower, reducing the fat storage even further, and that's perfectly fine to do. You're probably working out as a result of these slides that maintaining healthy weight actually is not really about calories. It's about, you guessed it, hormones, particularly insulin. Too many carbohydrates means too much insulin, too much fat storage, weight goes up. If we bring the carbohydrates down, the insulin levels go down, and fat is not being stored, weight comes down. And it really is as simple as that for most people. On this slide, we've mentioned a couple of other slides which you may have heard of. Serotonin and dopamine are sometimes called the feel-good hormones, and they're the sort of thing that, they kind of light up if somebody has a bit of cake. Well, that's not the best way to actually increase those kind of levels, and there are better ways to do that by lowering the carbohydrates. That's actually a more sustainable way to do that and to maintain a healthy weight. Alcohol is probably best quite restricted or not at all, and that's because alcohol does bad things to sleep patterns. Beer is sometimes called liquid bread because it's just so full of carbohydrates. There's also very little nutrition in it, and it'll sort of mess up sleep patterns and hormones. And as you can see on this slide, by reducing the amount of alcohol, we can actually reduce the sort of fluctuation in stress hormones such as cortisol. I don't need to labour the point about smoking. Smoking has been known to cause lung cancer since the 1950s, but actually there are plenty of other cancers that can be caused by smoking, and also heart disease and other things. Nothing good really happens from smoking. Exercise is phenomenally important, but perhaps not in the way that most people think it is. So a lot of people think about exercise in the context of weight loss, and actually for weight loss, it's really, really poor. What it does do is have benefits on hormones, and therefore reduces blood pressure, improves diabetic control. CV disease, by the way, is cardiovascular disease, so that's heart attacks and strokes. The Main exercise that we always sort of recommend is actually nothing more exciting than walking. NHS guidance is for about 150 minutes, so 2.5 hours per week. In an ideal world, chunking that down into maybe 3 walks of around 50 minutes probably has the best effect on hormones. But if that's too long, then more walks but of lower duration, 20 to 30 minutes, that'll be not quite as good, but not bad. Now, the pace is actually really important. So the pace of walking is important. We're not talking about sprinting, but we're also not talking about dawdling. The pace to go at is the pace that you can just about sustain a conversation. So you can have a conversation, but to be honest, you'd probably rather not. Any more than that, you're going to be feeling a little bit puffed out. That's the best pace to go, and that does really very, very exciting things in terms of hormones inside ourselves. Strength training is important. As we get older, we lose muscle and we become more liable to fall. If you're somebody who goes to the gym already, perfectly fine, just carry on. But if you're somebody who's got a bit out of shape, actually looking to get back into exercise, maybe after a period of an injury, then the 3 to 5 program here is a really good starting point. It's quite difficult to explain when we do these sessions, as I do with patients face to face in my own practice. I'll actually demonstrate. So what we're going to do is hopefully get a video together by the end of the week and upload that into the app. But very simply, depending on how well you're feeling, you might do 5 exercises. If you're not feeling that great on a particular day, you'll do 3. You'll do 3 to 5 repetitions of those exercises, again, depending on how robust you're feeling. You'll do 3 to 5 sets and 3 to 5 days per week. That's it in a nutshell. As I said, hopefully a video to come shortly. Now, stress. Stress is a short word, often misused and misunderstood, but to a clinician, a GP like myself, stress means, you got it, hormones, stress hormone, cortisol in particular. So what happens is that all of the things on the right-hand side have been shown to reduce some of the bad things that happen from stress. Cortisol levels will be down, insulin levels will be down, diabetes control improves, blood pressure improves, and this is all just from managing stress. Going for a walk, already mentioned going for a walk in the woods. The Japanese have a term for that. It's called Shinrin-yoku, and again has been shown to have beneficial effects on blood pressure, blood glucose, and even has a beneficial effect on the cells that fight cancer. But obviously in the context of what we're talking about tonight, regular walks, particularly in the woods, will hopefully have a beneficial effect on A&E risk. Sleep is absolutely crucial, and again, there's just not enough time or space to go through this tonight. A very, very detailed sleep protocol, it has been uploaded into the app, which you can access, and sleep is incredibly important, and it's no coincidence, is it, that sleep deprivation has been used forever as a form of torture. If we don't sleep, our hormones go all over the place, especially cortisol, and then all of the bad things happen. So there's been some really exciting research that's been done over about the last decade, showing how important it is to get a little bit of early morning sun into the back of our eyes, and that does some very, very powerful things to our sleep hormones. This is, I've got to say, this I would struggle with myself, avoiding caffeine for the first sort of hour and a half. That's tricky, but if you can, again, that does good things to stress and sleep hormones. A nap of around about 40 minutes. We call it 40 winks, don't we? Well, there's a reason for that. Actually, having a daytime nap of anything up to about 40 minutes can be absolutely fine and doesn't actually mess up the sleep cycle more generally. And then I'll just sort of round this particular slide off by saying that I think almost everybody really probably should be on a magnesium supplement and a vitamin D supplement. Magnesium is incredibly useful for brain function, for muscle function. Menopausal women actually find it very useful for helping with sweats and flushes. Social connections is really just a flash way of saying spending time with friends and family. And if somebody doesn't have friends and family, then perhaps consider a pet. There is actually research demonstrating that pet owners seem to live longer and have healthier lives. So final few slides. I've gone on a little bit longer than anticipated, but final few slides related to the Health and Wellbeing app and the coaches. Now, we are incredibly lucky that we are able to offer all modality patients, all 455,000 of them, access to a free health and wellbeing app, and through the app to a health and wellbeing coach. Now, for the purposes of this program, the app, accessing the app is absolutely, it's crucial, because that is where all of the information, so it will be uploaded. So there are effectively sort of two documents which have been chunked down and uploaded into the app. One is a very detailed nutrition plan, and one is a very detailed summary of tonight's session with much more information and many more resources. Over the course of the next few days, it won't happen instantly because we're doing another session like this later this week. So over the course of the next few days, you'll receive information on how to onboard, on how to get access to the app. You'll receive a link by phone, and that will enable you to onboard. It's absolutely crucial that you don't attempt to download the app from the App Store before you get that link. If you do that, you will be charged, but you have access to this for free. The back end, as it were, back end of the sort of the IT system recognizes your sort of personal details once you've received that link. And this is just a little sort of summary of the onboarding process. Now, health and wellbeing coaches are comparatively new to the NHS. Actually, they've been around in the medical world for just decades, but not so much in the NHS. Health and wellbeing coaches are experts in lifestyle change and nutrition. So very much the things that I've just briefed you on over the course of the preceding few slides. So stress management, sleep, nutrition, and there will be people who will at this point in time feel that they don't need a coach, and that's perfectly fine. But what I always say is that all of us have bumps in the road, and there is a bump in the road very close by. It's on the 25th of December. So Christmas isn't, this amazing sort of Hollywood thing for a lot of people. It's actually a tough time, and from a dietary perspective, it's a blooming disaster. Sometimes what people find is that they need coaches at certain times of the year or certain stressors. And in programs that we've done before, our patients have reported back in January that it was actually incredibly useful to have the coaches on tap, as it were, over the Christmas period to be able to just give that extra little bit of motivation and nutritional guidance. So even if you don't need them now, don't disregard them out of hand, because the time might come when you have a bump in the road. Just some sort of generic advice here, not particularly specific to this program. This is all available on the Modality Partnership website. And as you can see, just sort of covers some of the sort of more general things, such as heating one's home, being vaccinated, etc. As I said, this is all available on the Modality Partnership website. And then really just the final couple of slides. This is a really, really powerful way to improve health and well-being. And we obviously hope that it's going to be transformative, not just from the perspective of keeping you out of A&E in hospital, but also for longer term health and well-being. There's a phrase that some of you may be familiar with, adding life to years as well as years to life. And medication probably doesn't do either of those, whereas dealing with the basics and the fundamentals almost certainly does. If you take medication for your blood pressure or your diabetes, they may well need adjusting as you lose those insulin levels and the weight comes off. then the medication may need adjusting. That's a good thing. Don't worry about that. If you are on insulin for your diabetes, please measure your blood glucose carefully, because as those carbohydrate levels go down, then the insulin requirement will diminish as well. And it's therefore very important to measure blood glucose and alter your insulin accordingly. If you're one of those folks, and some people are, who don't always have your yearly long-term condition review, your yearly diabetes review, for instance, this is just perhaps a trigger for you to actually make sure you have that, either in the current year or in the following year. Partly that's because your medication may well need changing, but let's face it, if you go along and you have your blood test and your HbA1c has dropped substantially and you're coming off medication, then actually you'll get a pat on the back anyway, so that'll be quite nice. And then the final point, hopefully all of this will make you feel better, but if you do have any kind of symptoms that you're uncomfortable with, you're feeling poorly, or a couple of specific things that are mentioned on this slide, such as dizziness or lightheadedness, then just get in contact with your practice sooner rather than later, because it may well be that the medication needs a little bit of tweaking. And then the final slide is just a reminder that the entire point of this program is to improve your well-being short-term and longer term, and hopefully that means that you won't be needing this chap's services at any stage. And that, ladies and gentlemen, is me done. I will stop sharing my screen and then we can go over to questions. I hope I've stopped sharing now.
Yes, thanks, Dr. Bhardwaj. That is correct. You have to stop sharing. So, thank you very much for providing that presentation. I know I definitely learned some very interesting things in there, and it looks like there have been some people sending some questions in the chat. Please feel free. Obviously, this presentation or this Facebook Live or YouTube Live is going on for a full hour, so we've got 25 minutes now to obviously go through any questions that people might have regarding their conditions, obviously any helpful tips that we can get from both of our lovely speakers, both the doctors, both the partners. So starting off with the first question that came in from Lynn Hind. My hypertension is controlled. My medication I've been pre-diabetic for 10 years. I lost 3 stone, but it made no difference to my blood results, sadly. During COVID and shielding, it crept back up, and I'm 65, and my status of diabetes has not altered. Now, I'm thinking when she says 65, I think that might be that her HbA1c has gone up to 65, or no, maybe if she's pre-diabetic, it might be that she's age 65. But does somebody want to take this question? Panel? No?
Do you want me to, shall I deal with that, Tom? Yep, okay, all right. So, yeah, Lynn, this is, I got to say, perhaps not an entirely unusual sort of scenario. And I think I'm right in saying that perhaps the same Lynn has popped another comment right down at the bottom. So maybe I'll sort of deal with them together. Saying that mum's family were sort of late onset diabetics.
Yeah, so Lynn has also put a question in about
ages 65, HbA1c is 42, hence the pre-diabetes.
Yeah.
So there is almost certainly, I suspect, a bit of sort of refinement that could be done in terms of the dietary side of things. A lot of people do lose weight, but then struggle to keep it off. And we in the sort of medical profession know that just about every part of diabetes and hypertension and many other things got a lot worse during COVID for multiple factors. People weren't able to necessarily eat the way they wanted to, couldn't necessarily exercise, social connections disappeared. So in a way, the whole kind of COVID pandemic and how we had to deal with it was almost like an experiment in real time about the effect of the kind of stuff that we've that we sort of discussed tonight. And it was almost a kind of a vicious circle, because actually what we found was that those with diabetes got COVID a lot worse. So it was a real sort of a vicious cycle. So my sort of answer to Lynn's question is going to be that it may well be that the way that the weight loss was being done may not have been all that helpful for the sort of the underlying kind of health. So a bit like where medication, if you get to your HbA1c or your blood pressure through medication alone, that's not tackling the underlying sort of root cause. So if somebody is, let's say, on a kind of a high carbohydrate diet but calorie counting, then the underlying hormonal changes are still not really being tackled. There's almost certainly a calorie reduction, which will be helpful, but actually very difficult to sustain long term. And so by reducing carbohydrates, what tends to happen is that those hunger pangs, those sort of ravenous hunger pangs that occur, they actually tend to disappear. So most people who are following a low carbohydrate type diet will tend to find that they're able to sustain it more easily. Of course, there is a problem, and the problem is that we live in a high carb world. You go down any high street and try and get something, quick and easy to nibble on, if you're out doing the shopping on a Saturday, and it's hard work. So there is absolutely no doubt that it is harder work when one is sort of reliant on sort of shop bought food, because most of that tends to be very high carbohydrate. But that's where potentially going low carb means that you can just eat a little bit less. So again, just to come back to my example of maybe going out for a shop, going out to the shops on a Saturday, where you get to 1 o'clock and you're normally sort of thinking, all right, it's 1 o'clock, I'm hungry, I need some lunch. Well, actually, you may have had a bit of breakfast, which was a low carbohydrate breakfast, no muesli, typically no muesli, but actually you're not really needing anything for lunch, so you don't particularly need to pop into Greg's or wherever it might be, and you can just sail through quite happily till the evening. So that it should actually make the weight loss a little bit easier. The pre-diabetes, I would be reasonably confident that somebody with an HbA1c of 42 who goes down to 100 or so grams of carbohydrate, that 42 would disappear into the 30s. I would be reasonably confident. And I would anticipate that the blood pressure would follow suit as well. I hope I answered those questions. Just double check for me.
Yeah, Lynn had one other really good question actually about her exercise abilities. She said that due to the fact that she's had scleroderma for the last 15 years and other comorbidities associated with this, she's not been able to get out and walk any distance like she used to be able to. Do you have any advice on how she can potentially exercise to help her with her weight without necessarily needing to be on her feet?
Oh, okay. So it's actually being on the feet. Okay. So if it's a question of sort of struggling with sort of joint pains, then there are things that don't involve any kind of impact. I mean, in theory, walking by itself is pretty low impact. But if there are sort of issues, other kinds of things that cause, for instance, joint pains, then something sort of seated is probably better. So, for instance, maybe an exercise bike or a seated rower. There are exercise bikes which are they're called recumbent bikes. So they're actually you're actually sitting down with sort of legs out in front. Seated rowers, they can be very effective. And then there are sort of other things, and we kind of briefly alluded to them, such as the sort of the 3 to 5 kind of program. Although that's not walking, if you're sort of able to to kind of do those sort of exercises, and you're basically out of condition, then they will be slightly aerobic anyway. So most people get out of puff, and things like yoga. There's a YouTube channel called Yoga with Adrian, which is completely free, and for a lot of people that can be helpful as well.
Thank you. So moving on to another question. I hope that's answered your question, Lynn. Well, a few questions. Moving on to the next question. We've got a question from Christine Howard. Christine Howard has not slept very well for years after she gave up smoking 3 years ago. Her diet is up and down. She's on quite a lot of medication for blood pressure, cholesterol, and some other conditions. And she's recently been told that she's pre-diabetic. She's quite concerned about this, understandably, especially as she's had family members with diabetes in the past that were managed with insulin. Is there any particular sort of key bits of advice that, obviously you've mentioned quite a lot already, but is there any extra advice that you can think of for Christina today for her?
Shall I jump in and take this one?
Yeah.
So yeah, Christine, I mean, well done on giving up smoking. That's a really difficult thing to do, and that will have huge benefits for your health going forward. So well done on that, and it shows that you can make really big changes to your health. So I'd be confident that you can tackle the other things, and maybe the coaching program that we're offering can help you with that. So we strongly encourage you to sign up. I mean, certainly, as we've talked about in the presentation, sleep and blood pressure and diet are very much linked. If you're not sleeping well, it pushes up those stress hormones, those cortisol hormones. That pushes up your insulin as well, and all of a sudden you're more hungry. We all know what it's like when we haven't slept. It makes us crave comfort food, and that's our hormones taking over. So dealing with sleep will help with your diet, and dealing with sleep and diet will help with your blood pressure and with your pre-diabetes, as Dr. Bhardwaj has already spoken about. The types of things we can offer through our program should enable you to reduce your carbohydrates, eat a diet which is going to tackle all the problems you're describing. And if you, our coaches can also help you with sleep as well. There's some really excellent advice on sleep hygiene and improving sleep as part of the program. So hopefully all of those things together, working with our coaches just to get that little bit of extra support, can help improve all of these things for you. And it sounds like you may have had a little bit of a funny turn there as well. You're describing, so if you're worried about that, it sounds like you've had a bit of a frightening experience, then you should probably go and get that checked out with someone at your local GP practice. But I think your long-term health problems are really common across a lot of people in society, and that's what our program is set up to help you with. So hopefully we can assist.
Thanks, Tom. Perfect.
Shall I just jump in there just very briefly with magnesium? I think magnesium can be very, very helpful, Christine, for sleep. It's something that we think could well be a deficiency in our soil, and therefore anything that grows in the soil or anything that eats anything that grows in the soil, as it were, can be deficient. So it's pretty straightforward. It comes in multiple different forms. People of my vintage will recollect Epsom salts. Epsom salt is just magnesium, so you can sort of stick a bit in the bath and have a decent soak, and it'll actually absorb through the skin. But the dose requirement may be a little bit more. But I would definitely recommend trying that to help with the sleep. And sometimes it actually can be medication. You've written in the sort of chat that you're on a lot of medication for blood pressure and cholesterol and things, and actually depression. So sometimes paradoxically it can actually be the medication. So again, as Dr. Ratcliffe said, if we can try and help with the sort of the underlying kind of metabolic things, then you may actually find that you fix a lot of this relatively easily. I use the word relatively with a degree of caution, but it's entirely possible.
Lovely. Thank you, Vipan. One of the next questions we've got, I hope that's answered your question, but one of the next questions we've got is from Ken White, asking about his simvastatin. he is currently taking simvastatin, but he thinks that when the last time his cholesterol was checked, it was down at 3. He's a bit anxious about the side effects associated with this statin, and he's 74. Now, from my understanding, there's obviously lots of reasons why we use statins. And without sort of knowing a bit more details as to exactly your previous medical history, we wouldn't be able to advise exactly why you're probably on the statins. But one of the big things to obviously take into consideration is if you've ever had a patient who's had previous cardiovascular events, whether that's a heart attack or a stroke, there is more evidence for being on a statin than just reducing your cholesterol levels. It's also about stabilizing the cholesterol levels that are in your arteries and veins and stopping them from breaking off and causing and forming clots that can get stuck in other places. So I imagine that is possibly one of the things that is being considered in your case, Mr. White. Anybody else got anything else to say on that? No? I'll move on to the next question then. So the next question, we've got a question from, and I apologize if I don't say this name correctly, from Farbod Kanizadeh. I'll put it up on the screen. He's currently taking losartan and hydrochlorothiazide for his hypertension, and he's wondering whether his hypertension is possibly a secondary symptoms caused by another underlying health condition. And as a follow-up to that, he wants to know if there's any chance that in the future he'll be able to stop his medication.
Shall I can jump in first if you want, Vipan, or so. Yes, I mean, sometimes in a very small number of people there is some other underlying problem causing raised blood pressure, but for the vast majority of people, it's all about the metabolic syndrome, the things we've already talked about this evening. And what we've found is when people have followed the lifestyle advice we've laid out with some help and support from clinicians in your local practice and our coaches, that can make a massive difference. And I've certainly had lots of patients who've made these lifestyle changes, adopted the dietary approach we've talked about, lost weight, improved sleep and stress management, and they've managed to reverse their high blood pressure, come off their medication, and being able to lead much healthier lives as a result, without having to take daily pills and all of the side effects that come with them. So I don't know if you've got anything to add to that, Dr. Bhardwaj.
I think that's it, isn't it? So, as a general rule of thumb, if somebody has blood pressure at quite a young age, there may be some sort of genetic factors, but generally speaking, we would say that if you can do the basics, then there's a good chance not only of getting decent control, but potentially of coming off medication as well. So the underlying health conditions they're very, very rare.
Thank you very much. So I hope that's answered your question. Moving on to the next one, we've got a question from Adrian Thornton. He's recently had to unfortunately finish working after finding out about a medium abdominal aortic aneurysm, as well as some other conditions that he's suffering with, and is basically, in summary, wanting to ask about how far he can push himself in terms of the exercise. And is there, I'm guessing, and I'm sort of alluding to the fact that, is there a chance to sort of over-exercise that can cause problems, especially when you're dealing with other cardiac conditions? Obviously, we don't want to put too much pressure on our heart by exercising, but also we want to do a healthy amount. So I don't know if one of you can share some advice on sort of that side of things.
Happy to jump in there. So I think I would say this is somebody who definitely needs to just go easy and not be overdoing it. Walking is almost certainly going to be one of the best things. And again, we come back to pace. That sort of pace where you're able to sustain a conversation, but only just. Anything more and you're feeling a bit uncomfortable. So that's almost certainly should be the mainstay. And again, with both knees being a little bit problematic as well, and also the depression, I alluded to the fact that training in that kind of zone, where in that sort of range, then actually that does some really, really cool things to our hormones. Even the sort of the feel-good hormones. There are a few people who actually will have a stationary bike, and they will sort of just go onto the bike, and they'll be answering emails and things while they're on their bike, because they're not exercising so hard that they're just sort of perspiring and about to collapse in a heap. They're able to actually there's almost a sort of an elevated kind of mental function. So that's quite interesting. I think we're learning more and more about that. So I think walking would be a really good starting point. I actually think the 3 to 5 exercise, which is just body weight. There's no sort of weights involved, so you can't really overdo it. You might do a press up, for instance, or you might do a body weight squat. And those are things that most people can develop into doing, even if you can't do one right now. Body weight squats, many people lose the flexibility, but if you can just develop into it, start with, let's say, a half squat, squatting down into a chair, for instance, and then pushing back up again, there's no risk of sort of falling over. So actually, I think our sort of slightly low grade exercise program may well be just the ticket.
Perfect. Thank you very much, Dr. Bhardwaj. So there is some questions from Andrew Hamilton regarding a new medication that he's seen coming available on the NHS soon to help manage his diabetes. Rather than go into the specific details, what I'm going to say, Andrew, is obviously there are new medications that come out all the time, and it can take a little bit of a while before, one, the medication is actually available in community pharmacies for us to be able to give to patients, and two, for it to actually become available in terms of being written on prescriptions, as you've mentioned, based on the formulary. What I would say is keep an eye on the news and speak to your local surgery about when they're planning to get it on. Okay, and I hope that answers that question. It's definitely something you can discuss with the GP that you are under directly. We've had some very good questions, Dr. Bhardwaj, about magnesium.
Okay.
Specifically, how much magnesium should they be taking, and have you got any recommendations on the supplements themselves?
Excellent questions. So there are lots and lots of different types, which is in a way reassuring, but sometimes can be slightly annoying. And ultimately, I think there will be a degree of trial and error. Patients will sometimes say, "How do I know I'm getting it right?" Well, you know that you're getting it right when actually you're feeling quite good, you're sleeping quite well, and you haven't got any side effects. And the main side effect with magnesium, if you're slightly overdoing it, the main side effect will tend to be diarrhea. Nothing more sort of dramatic than that. So in terms of which type, I've already mentioned Epsom salts. Some people actually prefer a sort of a magnesium oil. So if you're somebody, for instance, that enjoys a massage, well, have a massage with magnesium oil. Some people prefer it that way. Again, it just absorbs through the skin. There are tablets, there are capsules, there are powder form magnesiums. It's really just a question of trial and error, and to some extent what suits your budget and your personal preference. Some of them are a bit more expensive, some a bit less. Some of them will be purer, some of them will be having some additives. It to an extent, it's personal preference. Try something, bog standard, stuff that you can buy from any kind of chain. If it works, then you're on to a winner straight away. If you think you need something a little bit different, then you can try that as well.
Thank you, Dr. Bhardwaj. We've very quickly running out of time. Just one very final question before we sort of sign off. Nazir Taladia is asked about his breakfast choices, and I just wondered if you could offer some good advice for low carb breakfast, very, very quickly.
So I always refer to Willy Wonka in Charlie and Chocolate Factory, who said that breakfast cereals were basically no better than pencil shavings. So I would always say avoid Weetabix. And if you want a low carb breakfast, there are sort of lots of options. Eggs, actually cheese. On the continent, people have cheese. yogurt, sort of a full fat yogurt. So a lot of our kind of diabetic patients have got used to me saying, just get some frozen berries, just put them in a pan, and you can do this, you can do this ahead of time. Put them in a pan, melt them down, or defrost them, not melt them, defrost them, and you've made yourself what the chefs called a compote, but which a patient of mine just said it's a mush. Yeah, it's a berry mush, and it's very tasty. And you can add that to 10% Greek yogurt. You can sprinkle some nuts on, and it's actually really delicious.
Perfect. Thank you very much, Dr. Bhardwaj. And I'd like to say thank you, obviously, from me, because I know I've definitely learned a lot this evening. There's definitely some things I need to change in my diet. That's for sure. And I want to say thank you to everyone who's joined us this evening from all across the country. And thank you to Dr. Tom Ratcliffe, and obviously thank you to Dr. Bhardwaj for joining us this evening. And if you have any more questions, do feel free to come back on Thursday, same time, where we'll be doing a similar conversation, maybe join 20 minutes or so in after we've gone through the same presentation you've already seen. But feel free to come back with some more questions. All right. Well, thank you very much for all your time, guys. And thank you again to everyone who's joined us.
Good night, everyone.